Hello, this slide presentation will be on drug therapy during pregnancy and breastfeeding. There really is a shortage of reliable data on toxicity from drugs during pregnancy and breastfeeding. In 2009, there was a program launched by the FDA, and up until recently, we had the categories of A, B, C, D, and X when we looked at medications and their safety and use in pregnancy, but those have recently been removed. They do remain for some of the OTC meds, but not for the prescription meds anymore. And there's just uh, a listing of mitigation of safety with medications without those categories now. So, two-thirds of pregnant patients take at least one medication, and most take more during their pregnancies, especially if they've already got other chronic illnesses for which they have to take medications. They're taking medications for pregnancy-related problems such as the nausea, constipation. They may be taking medications for the preeclampsia, which is the hypertension in pregnancy. They may have their chronic disorders, as I said, like hypertension, diabetes, epilepsy. They may have asthma. Um, they may be taking drugs for infectious diseases, for or for cancers. And of course, there's always the problem of drugs of abuse such as alcohol, cocaine, heroin, meth. Um, drug drug use of any kind during pregnancy is impacted by the physiologic changes of the body during pregnancy. One of the major ones is that the renal blood flow is doubled and excretion is accelerated during the third trimester. Therefore, the meds are not are transit through the body too quickly. Um, Another is the tone and mobility of the bowel is decreased, which can prolong the drug's effect because it's not excreted as quickly as it could be. Um, Again, we have to remember that there is placental drug transfer, um, and some can cross more easily than others, so we have to be careful about which drugs we use. And even though they've gotten away from using the categories of the A, B, C, D, and X, we still have to be very cautious with um, the effects of the drugs on the fetus, and making sure that we are using any drug as safely as possible. There are adverse reactions during pregnancy um, that can affect both the patient and the fetus. And some of the unique ones are heparin can cause osteoporosis during a pregnancy. And then, of course, prostaglandins can stimulate uterine contractions. So, women are advised, of course, not to take NSAIDs during their pregnancy. And certain pain relievers, when used during delivery, can depress the respiratory system of the neonate. Or if they're using illicit drugs, it can do the same thing, of course. We also, of course, worry about gross malformations such as cleft palate, cleft foot, hydrocephalus, the neurobehavioral, and any metabolic anomalies that can occur. And that teratogenesis, the incidence and causes of congenital anomalies, that there's less than 1% of all birth defects are caused by drugs, but when they are caused by drugs, it can be a serious issue for the prescriber involved in that. So you must identify any teratogens if you can, but that can be difficult to do. And as a result, only a few drugs are considered proven teratogens with a pregnant patient. So, how do you minimize that? They should avoid any unnecessary drug use. So, we know that, of course, alcohol and any illicit drug use should be avoided. And then, of course, the certain drugs we mentioned earlier, like heparin or anything that that stimulates prostaglandins, should be avoided, as well as anything for respiratory depression of the fetus. Uh, we respond to teratogenic exposure by identifying the details of exposure, by doing ultrasound scans to make sure that everything with the fetus looks okay. You know, one of the important things with teratogenesis is the stage of development of the fetus. So, development basically occurs in three stages. You have conception through 2 weeks, you have the embryonic stage, which is weeks 3 through 8, and this is where most of the gross malformations caused by teratogens can occur. And then you have the fetal period, which is week 9 through delivery, and functions are disrupted. So the malformations are through week 8, and the problem with that, of course, is that the women do not many times know that they are pregnant, especially those that are uh, abusing drugs. They have no idea that they are pregnant yet. So they continue to use their illicit drugs, or even if it's a patient who just has to take meds for a certain medical condition, they may not know that they're pregnant yet. So the risk that they've already caused malformations is greater. And then from then till delivery, we have to make sure that any drugs that we use will not cause functional problems, uh, neurodevelopmental problems, or behavioral problems with the child. Here is the categories that I mentioned earlier that are no longer being listed, uh, but are still considered for some of the OTC medications. But knowing that what they mean is still important. Uh, what about drug therapy and breastfeeding? Well, we've already discussed in previous lectures that the drugs can be excreted in the breast milk and have an effect on the infant, and that's important again to convey to the mother, because sometimes they think it's just when they have before they've delivered, and that the meds won't cross into the breast milk, and they need to know that they cannot restart certain medications after delivery because of that. So how do you decrease the risk to the infant? You take the meds immediately after breastfeeding. Therefore, hopefully they've cleared enough so that the baby won't get amounts that could be harmful. You avoid drugs that have long half-lives. You choose drugs that tend to be excluded from the milk and that are less likely to affect the infant. And then you avoid, of course, all the illicit drug use. So your first question here is, the infants delivered by a patient suspected of using alcohol and cocaine regularly, what do you want to observe the child for? And the answer here is B, the high pitched cry, vomiting, and jitters. Because of the cocaine use, the child would be having withdrawals, and that would be a symptom of those withdrawals. If a patient is taking a category A drug during pregnancy, um, the answer here would be A. Um, it has the least amount of risk, and even though we're not using this on a widespread basis anymore, it is still good to know, because something like acetaminophen would be an A. Your insulin would be an A for the patient, their vitamins, okay? And the next question. Patient is 2 months pregnant and complains of gastric distress. What is the most appropriate thing to do? The answer is B. The first thing you want to do is assess and educate on lifestyle modifications for the patient so that there is no harm to the patient. You would not give Cytotec. That would not be used. If we were using that classification system, that would be an X. Um, Cytotec is actually used to induce labor, so that would totally not be used. Um, you would not use the Pepto-Bismol, and you would not use valerian root as a supplement. The last question: a patient's breastfeeding her newborn is prescribed an antibiotic. Which would you want to include in instructions? And the safest thing to do would be number D, which would be to take the antibiotic immediately after breastfeeding so that while the med is working, the mom is not getting ready to breastfeed. Okay? And that is it for this lecture. Thank you very much.